Welcome to EASL Studio, your weekly hepatology broadcast news. My name is Wim Laleman, and I'm an endohepatologist working at the University Hospitals Leuven, Belgium, and Münster, Germany. In today's episode, we will focus on endohepatology, or when hepatology meets endoscopy. I'm sure the endoscopist would say the inverse. For those who are less familiar with the concept, endohepatology is an emerging field in which advanced diagnostic and therapeutic applications, such as, for example, EUS-guided liver biopsy, EUS-guided portal pressure measurement, are integrated within the practice of hepatology. These novel procedures have the capability to improve the journey and outcome of a patient with liver disease and may even challenge current golden standards, which of course leads to lots of opinions and open questions, which I'm happy to discuss today with my fellow panelists. The first colleague is Professor Reem, who is an advanced endoscopist and expert bariatric endoscopy from Cornell University, USA. The second colleague is Professor Gavin Johnson from University College London, who is also an advanced endoscopist and member of the Educational Committee of SGE. And finally, we have Professor Andres Cardenas from Hospital Clinic Barcelona, whom you all know as an esteemed colleague endohepatologist from EASL. So welcome to you all. Delighted to have you here. I'm looking forward to an interesting discussion. And I would like to touch home base, Andres. You know that for more contemplative oriented hepatologist and pure advanced luminal endoscopist, endohepatology is a bit of a no man's land. So I'm interested to hear from you how you would see or say that endohepatology is integrated within the hepatological community. So what's your take on that?
Well, thank you, Wim. It's a real pleasure to be here. And as Wim says, this is an emerging field. The role of endoscopy and hepatology has been always it's always been around. I mean, when we train as gastroenterologists and hepatologists, we're exposed to endoscopy. However, with these new techniques with EUS. And also, we'll talk about endobariatric endoscopy. There's more awareness of their applicability. We see more and more publications. We see that these patients are usually referred to us sometimes for liver biopsies. Sometimes these patients will also be candidates for endoscopic therapies for obesity if they have MASLD. But certainly there is now more and more awareness among the hepatology community. We at EASL have actually been very proactive on this topic, and we've partnered with the ESGE and have we have meetings at both societies about the different topics. And I think that within the field, there's more awareness, although there's some skepticism on some procedures. For instance, the EUS portal pressure gradient measurement there's always the discussion if HVPG is better or not. But the reality is that EUS guided therapies for liver diseases are here and are probably here to stay. And we not only have, obviously, we don't only have liver biopsy, but we have blood pressure measurement. We can also have cytology, aspiration, and there are a number of other procedures. So there's interest, and people within the hepatology community are interested in knowing about these procedures and knowing if they, one, can do them, if they get trained, and two, when to refer and who should they refer to.
Okay. I'm curious, Gavin, you as a pure endoscopist, what's your take on this? Do you see this as the hepatologist invading the endoscopy realm, or what's your take on this? I'm very curious to hear your view on this.
I think a lot of these, both diagnostic and therapeutic EOS offerings in the world of hepatology are such that you need to be a pretty experienced endosonographer with the long learning curve that entails to be able to deliver them. I think that some of these are more of the trickier ends of certainly diagnostic, elastography, contrast, etc., for delineating liver lesions, and then some of the therapeutics that we're going to talk about. You need to know your way around an EUS scope. Your training is going to have been long. So how practicable is it to have trained in hepatology to the level that we see around the world, and also be an advanced EUS therapist. So I think there's going to have to be some sort of discussion about how best to train up the numbers needed. If we convince you in the next half hour that this is indeed a role that in the next 5 to 10 years will become mainstream, which I think many of these modalities and interventions will, I declare a bias there, then I think we need to start discussing how we're going to increase the workforce to meet what could potentially be a pretty exciting and explosive intervention, both on the bariatric side and the endohepatology side.
There are examples, however. I mean, if I'm the advocate's devil, rectal surgeons, for example, do rectal ultrasound themselves. So there might be a space or room for a dedicated intervention. Like if you would have endoscopic proficiency as a hepatologist, it might be possible to get a kind of focus training for endohepatologists. Endohepatology, you think, or would you exclude this as an option?
I have always pushed back on that to train up specifically for one or two particular EUS interventions, because it's when the anatomy doesn't fit, you start doing things you perhaps shouldn't. And I think the learning curve of diagnostic EUS, certainly ESG curriculum talks about 250 diagnostic. That's the same in the UK as numbers we say people need on their way through. Most of that is to learn the anatomy that you're looking at and learn how to handle a linear echo endoscope. So as soon as you start putting needles in or wires in, then you need to have seen all the different variations of that anatomy to be competent. So I don't think there's a shortcut straight to endohepatology as I see it, if I'm honest.
That's a very honest answer. Thank you. Reem, you're our transatlantic link. So what's the take in the USA on this evolving field? Do you have the same opinions, or do you hear the same opinions as Andres and Gavin have already put forward? Or is there still another take on the emergence of endohepatology?
I think it's very similar. The key thing is it needs buy-in from the hepatologists and the transplant group. So with us at Cornell, I'm fortunate to work with both hepatologists and transplant hepatologists, because they're sort of sometimes a little bit separate, that support us. So they would send us patients for either, if they have MASLs, for sort of the one-stop shop of doing an endoscopy, a liver biopsy, portal pressure measurements, or on the flip side, if I'm doing an ERCP on someone who's a transplant patient with abnormal liver function tests that may need an EUS liver biopsy if their ERCP is completely normal. So we would end up doing it from both. I think the key thing is showing them that there's no complications or very low risk of complications, and patients like it because the recovery is much faster than a percutaneous liver biopsy, and you can maybe get more information from the EUS liver biopsy portal pressure pathway.
Okay. So if I summarize, what I hear from you guys is, in fact, that we should start putting people together. So advanced endoscopists and hepatologists, and we should learn to from each other. So the endoscopist should learn from the hepatologist, and the hepatologist from the endoscopist. What does this mean, Gavin? You as one of the representatives of SGE, how do you see that collaboration? I think Andres already alluded to one. We have the joint online course for endoscopy in liver disease, but how do you see this field evolving, and what's your take on this from the SGE perspective?
Yeah, well, I think more joint working groups to really upscale this, to train up, to disseminate what evidence there is, and to think about improving what evidence there needs to be. I think a joint task force between EASL and ESGE would be excellent. I think we're beginning to see that. So I think, Wim, you spoke at the EASL joint session in ESG Days in Berlin, a very successful endoscopy conference that was a month or so ago. There's more to it than joint sessions at each other's conferences, of course. I think there's a real appetite and desire to work more closely.
Yeah, we've been having these for 4 years. So, the idea is to actually collaborate more, perhaps put together documents or position statements on these procedures. And just to be a little bit devil's advocate. You do have to realize that these procedures, although they're here and they're probably here to stay, and portal pressure measurement and biopsy are gold standard. There's also very active research going on for non-invasive markers of biopsy and also non-invasive markers of portal pressure. So at the same time, it's an evolving field. Right now, these are great tools. We have to see what the future holds, because there's active, interest in also doing non-invasive procedures, particularly in patients that have decompensated liver disease, which are, more at risk for adverse events if they get these procedures.
Okay, I think most people in the audience will probably be interested in our views on some of the particular applications that are already in clinical practice or are knocking on the door. So if I start with the EUS-guided liver biopsy, I'm looking at you, Gavin, but also Reem and Andres. EUS-guided liver biopsy, I mean, the echo I get from my colleagues is, why would we need another way of sampling tissue if we already have the percutaneous and the transjugular, and the transjugular you can combine with the HVPG. So why do we need an endosonographer to take liver tissue? So what would be your take on that, and how do you implement EUS-guided liver biopsy in your practice?
Okay, so I think the first thing to sort of get out the traps with, in answer to does it add to the other two modalities, is that it most certainly does. We know that it is safe. We know that it is effective in terms of the length of the cause, the ability to make a diagnosis in probably 95% of the time, the number of portal tracks, more than 11, etc. There's studies now, meta-analyses that back that up. So we know that it's effective. And we also know that it's acceptable to patients. They quite like the idea that they will be sedated. We don't want to be doing too many biopsies in these patients, but doing a second biopsy on them is rarely the headache that it can be if somebody's gone through a percutaneous biopsy. And furthermore, we can biopsy both left and right sides of the liver, which is often of interest to a surgeon, particularly prior to surgical planning and liver resections and so on. So I don't think it's going to replace the other two modalities, but I think if you're sat in your MDTs, your liver meetings, and you've got a decision to make that a patient needs a biopsy, and they need an endoscopy for other reasons, so variceal staging or perhaps portal pressures in when that hits the mainstream, then there's definitely a role for this. To be honest with you, I'm surprised that it's not really gained traction as being a more go-to, first out the traps, non-targeted liver biopsy modality, as it seems to have done, based on the acceptability and the meta-analyses. I think one ought to also point out the limitations. The sort of organizational limitations are that of having enough capacity on EUS lists to what is a large volume of work. That's certainly a problem in the UK, no question about that. And the second limitation is that there are blind spots to the liver, particularly on the right inferior liver, that you may not see, but in a non-targeted biopsy, that's probably not a problem. Obviously, that's an issue for a more targeted biopsy or lesion evaluation, but we're not really talking about that in this sense. So yeah, I think the data's convincing, and I think we're going to start seeing an awful lot more of it, subject to workforce being able to take these on.
Okay, Reem, I'm turning to, yeah, please go ahead.
No, I was going to say, just to add to that and to what Andres said earlier, a lot of my referrals specifically come from the hepatologist that sees fatty liver or MASLs, and so they do the FibroScan, and if FibroScan sometimes in patients with obesity isn't sort of very sensitive, they'll send them for an MRE. But then if those are inconclusive or the MRE shows fibrosis, then those are the patients that we end up doing an endoscopy and a endoscopic liver biopsy with portal pressure measurements. And there is data sort of supporting that the portal pressure measurements that we do are a little bit better than the portal pressures that you get done via interventional radiology, and they're more accurate.
Right. The measures you get via HVPG underestimate portal pressure. So you get
especially
patients
in fatty liver.
Right, with the MASLD that can decompensate at a lower degree of portal pressure. So that's one of the active areas of research, is defining the role of EUS PPG and MASLD. In other diseases like viral hepatitis and alcoholic liver disease, we've known for years that HPPG, it reliably will give you an estimate in terms of rebleeding and survival. With the MASLD, this is a different story. And perhaps with cholestatic liver disease, that's also a different story.
Okay, now that we're at the topic of EUS PPG, so we're running ahead, but this is fine because this brings you automatically to the point. I'm very fascinated, Reem, by hearing you say that you already combine the EUS biopsy with the portal pressure. Although there is some skepticism from out of the scientific societies that in fact we are Andres and me are part of the Baveno collaborative group, and of course, as Andres already mentioned, HVPG has been in fact the backbone for a lot of knowledge in portal hypertension. This is the golden standard, yet a lot of cohorts are being published from the States where there is in fact no clear direct correlation with HVPG. So how is this perceived in the States? Because in Europe, I mean, people are interested, and I'm speaking also on my own behalf, but there is still lack of data that really correlates the HVPG to the golden standard, to the EUS PPG. So what's the take of people on that in the States? Because there we see cohorts of hundreds of people being measured, and that who take this in fact for granted. So I'm really interested to see your take on that.
No, I agree with you. I mean, I think that the actual trial that is currently being done in Europe is correlating the the HPPG with the portal pressure measurements, and that's still ongoing, is my understanding. I think the company had a little bit of product delay, and so that I think delayed a little bit the trial. But in the US, we've correlated it with sort of non-invasive markers. But even more so than portal pressure measurements is the EUS elastography measurements that we are sort of getting. We still don't understand the numbers and what they mean. And so I think more research is being done on that. I think it's important, if you're doing it, to do it as part of either to follow them up. So I've had patients with slightly elevated portal pressure measurements. So it's between 5 and 10. So it's not clinically significant. And then seeing if that changes with weight loss or not. But we really need the correlation, because that's obviously the next needed step, or the results of that study.
We did the study in Leuven. So together with my colleagues, Halk van der Merwe, and the colleagues in Barcelona, we finished the trial. So I hope the results will be out.
Okay.
Yeah. So that's the question why. So the other point you touch is also one of the things I wanted to discuss with you. We have, of course, FibroScan, and we also have the availability of elastography, but you already alluded to it that we are just starting to explore it. Do you think this will live up to the same expectations as we have from FibroScan, for example, or shear wave elastography done at conventional ultrasound? Or what's your take on that?
I think we need to sort of really understand how the shear wave, I mean, we understand how it works, but we really need the correlation data. And I know that data is forthcoming. There were a couple of studies that were published in abstract format or presented last year and maybe earlier this year. But we really need the full publications to sort of see what it all means and how it really correlates. We've looked at our data, and I think there are some markers that correlate. I think there is a little bit of a learning curve where to put the box when you're doing the shear wave, how many areas and the averages of those. But I think that's even more non-invasive than portal pressure. So it'll be interesting to see. We know that with FibroScans, if you have obesity, it's not accurate. And then there are limitations with that. So maybe that can be overcome with the EUS route.
Exactly. Because obviously FibroScan is also a tool for population screening for fibrosis and patients at risk. And these patients usually don't undergo endoscopy in the primary care setting. But certainly what you point out to with patients who are very obese, where it's difficult to obtain a reliable measure, then you certainly have these tools that can certainly help you with elastography and perhaps biopsy. And getting to the point with Gavin said, the probably the reason why most patients are not getting EUS-guided biopsies in practice is perhaps one, availability of people who are trained to do it. Two, reimbursement may be an issue. I don't know about that. But three, is this something you're teaching your fellows actively in their training year?
You're addressing the question to Gavin. Okay.
Gavin.
Well, there's not many units in the UK where this would be go-to first out the traps. We're doing a few in sort of niche situations when it comes through, but it's not generally from the liver unit I'm attached to. They're all free because of their access to radiology, which is a huge and very good department. I think some units in the UK it now is mainstream, and without question, their fellows will be training up in this. But I think as it gains traction, the fellows will follow suit. I think if you're used to using the FNB needles, there's obviously a different trick to it. We're not going to get into technicalities of how to do it today. We don't have time, but I think if you're familiar with an FNB needle at EUS, it's a small leap to be able to very successfully undertake a non-targeted liver biopsy from both left and right. Okay. So I don't think that would be a big problem in itself.
In the sake of time, I wanted to make use of the expertise of Reem as a bariatric endoscopist. A lot of our patients, Reem, of course, and it's the same and even more in the US, suffer, of course, from metabolic syndrome. So we are very fascinated by the MASLD concept. We, of course, as hepatologists, have always been looking at medication for intervention. But how do you see the future of bariatric endohepatology? Because I think this is one of the ignored interventions, at least in hepatology, because we always look at medications and how we can influence fibrosis, inflammation by pharmacotherapy. But I think we should also start to explore that option, or am I wrong? I presume not.
No, I agree with you. I think that's the sort of $1 million or euro question. The main thing is that, with the advent of medications, and we have more and more better medications. There's a new medication that just got approved in the US. That's not necessarily for weight reduction, resmetirom, yeah. And that basically reduces reduces fat in the liver and improves fibrosis. But it's not necessarily for weight loss, and ongoing trials are for the GLP-1s like semaglutide and tirzepatide. And I think people and hepatologists are probably more wanting to use these medications as first-line therapy for these issues, and that's okay, because I think people want to use medications before they do endoscopy. But where I think endoscopy can come into play, specifically endobariatrics, is that you're not going to want to be on medications for the rest of your life. NICE approved Ozempic or semaglutide for a period of 2 years. So what happens after 2 years? You may need something more to help with that. And we talked offline also about the cost effectiveness of these medications. They're very effective if taken, but if not taken, they're not effective, obviously. You lose the effectiveness once you stop taking them. But they're also very costly, and they're more costly in the US than in Europe. So we looked at this as part of a cost effectiveness analysis, and it needs to cost, at least in the States, less than $1,300 a year to be cost effective. And at the moment, it costs that much a month. And so we're ways away from it being cost effective.
As you have the best oversight in all of these applications, for people who are not so acquainted with bariatric endoscopy, and I presume a lot of our audience, which are the trends or techniques that you would advise us as hepatologists to follow up upon in the near future? Are there, I can imagine that there are several techniques and methods. Some are here to stay, some are short-lived. So what in your view is one of those interventions that really can go a long way?
So I know to get improvements in muscle, you need to get at least a 7% or more total body weight loss. So you want any intervention that will get you to that. And sometimes you may need a combination of interventions. The ASGE and ESG just published guidelines that talk about the different therapies. The two main ones I would say that would help with this, that are probably approved and have the most data, are the endobariatric, the endoscopic balloons, that there are several approved in Europe and a few as well in the US. And those give you about a 7 to 10% total body weight loss. The problem with those is that once the balloon is out, similar to stopping medications, you have weight regain. But that's a fairly easy, simple therapy that has less side effects. The one with the more data are plication therapies or suturing, and there are several devices that are approved in Europe. For this, the most data probably comes from the endoscopic suturing device that's used to be Apollo, now Boston Scientific. And it basically plicates the stomach from the inside, making it smaller. And that has good data for up to 5 years, showing durability of the sutures and durability of the weight loss with improvement in outcomes.
Okay, thank you very much for those insights. In the sake of time, we have to move on because the time is going fast or is flying by very fast. In the last couple of minutes that we have left, I would like to hear from each panelist how you think we could achieve greater adaptation of some of the techniques that we have mentioned. What hurdles are there to be expected or to be overcome? And how each of you, from your own perspective, would see the future of endohepatology. So 3 questions. And I would like to start with Gavin, maybe, or Andres. Gavin?
I can go first,
Yeah.
if that's okay. So I think we've talked several times here about data being on its way, both for shear and elasto and portal pressure gradients via EUS. I think that's hugely important, because until we can convince that it plays a part and is accurate and correlates, and in certain avenues such as Model D and non-cirrhotic portal hypertension, it may even be favorable. I think that's probably the biggest hurdle in where I'm working. And then hope that we're not saying we hope that there won't be non-invasive modalities, that they're going to evolve too. But I think if they come on stream, we have to prepare for the fact that we may not be doing as much as this as we think we might. And then, as I've alluded to before, there's a workforce and unit development issue to be met here.
Okay, Andres, you want to add something to that?
I completely agree with Gavin, and the issue is obviously hurdles is one, achieving that people know about these procedures, both people who practice hepatology and people who practice gastroenterology, and also endoscopists know about these procedures, and waiting for the studies to come out, and also achieving competency, and who's trained to do this, who should be doing this, who should be referring patients. And for this reason, I believe the joint society perspective is good. As I mentioned before, EASL and ESG have partnered in this area. And perhaps the ASG and ASLD have done this at the ASLD meeting. There's always an ASGE course. But certainly the hurdles are going to be, what place do these procedures have in our patients? Because we do have competitors. You have non-invasive techniques that are also in the pipeline. You have medications, and you have obviously preventative strategies of preventing people from getting advanced liver disease. So obviously hurdles are going to be those, and another hurdle is going to be cost and cost effectiveness, as Reem alluded to.
Okay, Reem, do you have a particular take on this?
It's always hard to go last, but I agree with everything everyone said.
It's always
I think
a good attitude.
more data.
Yeah, that's for sure. So I think we're I think we are, this is a good closing remark. I think we are really at the frontiers of advancing the field and
get people to work together as
Yeah,
teams. So
absolutely.
you have an endoscopist who maybe be the person that the hepatology team or the hepatologist can talk to and sort of create teams and working teams together. And include liver transplant surgeons, and include transplant hepatologists, and you should also include gastroenterologists to do hospitalist work. So it's a team effort. It's not only two specialties. I think we should all have a lot of people involved in this area.
I think EASL would not like to hear it, but I think we're ready for a European American Association for the Study of the Liver and Endoscopy, the EASLE. Maybe that's stuff for another studio, but at least I would like to thank you all for your input. I think it was really valuable from each of your perspectives. I would like to thank the audience for their attention. And I would like to point out that next week will already be the last episode of this season. So in honor of the United States Viral Hepatitis Awareness Month, Professor Thomas Burke, and his guest speakers will take us on a tour on the current landscape of the field of viral hepatitis. So thank you for listening and joining in. And remember to become a member and join the EASL family, and maybe see you in Milano. Have a great evening. Bye.
Thank you.
Thank you.
Thank you.